Yes, sir. We can see the slides of yours, Shastri sir. Sir, your voice is not coming, sir.
Are we good to go?
Your voice is not coming, Shastri sir. Voice, you are not audible, sir.
म्यूट आप अनम्यूट करना पड़ेगा आई थिंक.
अनम्यूट तो है सर. ऑडियो कनेक्ट नहीं हुआ है सर. आई थिंक you may log out and log in again. That may help. Sir, can you just stop screen sharing so that we can proceed ahead? Yeah, thank you, sir. Nirav?
Yes, sir, we good to go.
Yes.
Yeah. So, good evening, everyone. We welcome you all for this no thrombosis session. So this no thrombosis is very well-known platform and the awarded platform as a most engaging scientific platform by any pharma company. So to go ahead with the today's session, we are having with us the course director of today's session, Dr. S.C. Manchanda sir. I'll give the brief introduction of all the faculties, starting with Dr. S.C. Manchanda sir, who is a course director of today's session. Sir is a senior consultant cardiologist at Sir Gangaram Hospital, Delhi. So he is a senior consultant and coordinator of the Diplomat of National Board Program of the National Board Examinations, and a former professor and head of Department of Cardiology at AIIMS, New Delhi. Sir has worked at AIIMS for 36 years and superannuated from the institution in 2003 to join Sir Gangaram Hospital in the Indian capital city as senior consultant cardiologist. Sir has presented numerous research papers and has written for several journals. Today, we are having with us Dr. Tapish Sahu sir. Sir is a moderator of today's session. Sir has completed MD, DNB FSCC, FESC. Sir is a fellow vascular and endovascular surgery, Salzburg. Sir is a senior consultant, division of peripheral vascular and endovascular sciences, Medanta, the Medicity Hospital, Gurgaon. Sir has published many articles and also involved in research trial. The second moderator of today's session, we are having with us Dr. Kapil Gupta sir. Sir has completed MS, DNB in vascular surgery, FAVIA from USA. Sir is a senior consultant and in charge at Peripheral Vascular and Endovascular Surgery, Max Healthcare, Delhi. Sir is a life member of Vascular Society of India and associate fellow of the Asia Pacific Vascular Society. Sir has participated in many national and international level conferences. We are having the speaker of today's session, Dr. Digvijay Sharma sir. Sir is a head and senior consultant vascular intervention and surgery at Fortis Escort Heart Institute, Delhi. The second speaker of today's session is Dr. N.R. Shastri sir. Sir is consultant preventive and non-invasive cardiology associated with Mulchand Hospital, Delhi. The another speaker of today's session, Dr. Rohit Goyal sir. Sir has done MD in medicine, DM in cardiology. Sir is consultant interventional cardiologist associated with Fortis Memorial Hospital, Gurgaon. The agenda of today's session would be the opening remarks will be given by our course director and the moderators. Then we'll be having 3 case presentations and the discussion after each case presentation. The first case presentation will be by Dr. Digvijay Sharma sir, followed by the presentation by Dr. N.R. Shastri sir, and the third presentation by Dr. Rohit Goyal sir. After that, we'll be having a discussion and the concluding remarks by course director and moderator of the sessions, and followed by the vote of thanks by Emcure. So with this, I hand over the session to Manchanda sir. Over to you, sir.
Thank you. It's an honor to be the course director for this prestigious course on no thrombosis. I also like to call it no clot. As you know that nature had made this clotting mechanism to protect us. When the ancient man in the olden times used to live, he used to get lots of cuts, etc. And he used to fight with the animals, and also the clotting was a protective mechanism. If he got scratches, etc., he will become all right. So this is really a protective phenomenon. But what has happened is, over the years, that this clot has become the biggest killer of mankind, because this clot doesn't kill from outside, it kills from inside. Because of our lifestyle, I think our inside has become very defective. You know, coronary artery disease, how it damages the arteries and all. So the clot forms there, and we get coronary artery disease, myocardial infarction, which is a very, very dangerous condition. Similarly, there are other conditions in which I think inside of the body, the clots have become really a big challenge. For example, you all know an atrial fibrillation is a big problem. Similarly, deep vein thrombosis and so on. So I think most of the vascular diseases, whether they are coronary artery disease, peripheral vascular disease, even venous thrombosis, etc., pulmonary embolism, have become a big challenge for mankind. Of course, as I said, the clot is really a protective phenomenon, but once it occurs inside the body, and it can really harm, because and the treatment for all this initially is to, of course, change our inside of the body, that is to have lifestyle modifications. But once the lifestyle is defective, I think these clots form. Now, as you heard that this no thrombosis workshop has been done for quite a few days, quite a few months now, and the aim you heard is to really make the physicians and the cardiologists and the all the internists aware why this clot occurs, how to prevent it, and then how to effectively treat it. Fortunately, we have several medicines which are available. At one time, we had really nothing. I've been in practice for the last more than 50 years and all. We had really nothing to prevent this clot inside. We used to say, yes, there is an arterial clot, which is a white clot. We could do with the antiplatelets. But the other clot, we had hardly anything. We had, of course, drugs like heparin, etc., which were very difficult. And then these VK, that's vitamin K antagonists, they were also very cumbersome. But now we have so many medicines which can be given very safely, and they have really changed the outlook of the management of these patients with the clot formation. So I think I would say the slogan of this no thrombosis is that there should be no thrombosis in the inside of the vessels, whether they're veins or arteries. And if it occurs, the best is prevention. Of course, if it occurs, then how to control it with the effective drugs. And therefore, I think this is being done with the help of 3 case presentations, because case presentations really teach us the maximum. The real case scenario will be presented by 3 speakers. And I am very lucky that I have very eminent moderators to run this course, and very good speakers and all. So without taking much time, I would like to hand over to the moderators. Maybe Dr. Kapil will like to take over.
Very good evening, sir. Welcome. So thank you so much, Emcure team, and for inviting me for this session. So we'll be having 3 talks, as sir has already discussed. The first talk will be by Dr. Digvijay. So let's start from him.
Am I visible?
Yes, sir, you're visible and you're audible also.
So thanks, Kapil. It was very nice to see Manchanda sir there and Tapish Bhai BA. So we'll start the no thrombosis thing with a case I did today. Now this case was referred to me on Saturday for varicose vein. by my referral team. So when I checked out the patient, I find that she has got huge vulval varicosities, and the varicosities and flaring is up right up to the thigh and buttock. So I took some history, and I was told that she had a DVT sometime back, and then she's never been all right since then. When I walked up, she has got a very tight iliac vein stenosis. So 45-year-old female, right leg pain with varicosity, past history of DVT, same leg which was unprovoked. Doppler was like typical SFJ reflux and multiple incompetent perforating veins. But when I expose the lady and I check her up, there is gross varicosity and hypogastric region. So I get a CT venogram which shows a complete CTO of the iliac vein. This is how it looked like when I took my first shot on the joint. There was no way I could feel it in both sides, so I had to go from the top. And this is a total block when I take a jugular access. Managed to cross the wire, opened up the channel, and then able to put in a stent from down below. This is how it is. So free flow to the thing was achieved, and this is just to tell the Emcure people that yes, Exafib is being written by most of us nowadays. It is a very simple case. Now, what are the take-home points? Take-home points are: 1, varicose veins can be secondary. Proper history and physical examination is must. Once a person has got DVT, post-thrombotic syndromes are a genuine entity, and if they involve the suprainguinal section of the venous system, they must be dealt with specifically in younger patients. Otherwise, there is high risk of either a recurrence of DVT or very bad leg. So I will repeat: secondary varicose veins exist. We must be very clinical oriented. It is not only biochemistry and ultrasound. You have to expose the patient and take a proper history. Now, this is very important. Anticoagulation has a role. Why do I say this? Because if that patient had got the ideal treatment of DVT at the right time, maybe she would not have had a post-thrombotic syndrome, which will be seen in approximately 60% of your extensive suprainguinal DVT patients. This is one of the reasons why DVT has to be dealt with aggressively, if possible, at the right time and completely. The cause had to be removed. And we must always remember Virchow's triad when we see a clot. Either there is a trauma, either there is a obstruction, or there is some thrombophilia pack. This lady was still under anticoagulation when she came to me. She will stay in anticoagulation move for at least 3 months. Then we'll do the thrombophilia pack and make sure that she has nothing else. And that is the time when the treatment is complete. So I will repeat: secondary varicose veins exist, and anticoagulation has got a big role done at the right time in the right amount to prevent post-thrombotic syndrome or in acute stages pulmonary embolism. Thank you so much.
Thank you, sir, for a short and crisp case. So there will be some questions. So I'd like to start questions. Well, when you have seen this patient having secondary varicose veins or you diagnose as secondary varicose veins, what basic investigation you do before you plan an intervention? Do you do a CT scan or you rely on on-table DSA?
Okay, it is a good question. Once I know that this patient has got a history of DVT, and I find long tortuous veins in the abdomen and the back, I do think of iliac vein stenosis. It's like hair. Now I have two things. Best would be IVUS, but in very big CTOs, you cannot cross that lesion anyway, you won't know. So CT venogram was done for this particular patient. For sizing, if I'm not sure, I would do also IVUS to land my stent properly. But here it was such a clear-cut case that CT venogram and proceed. I wanted to avoid a stent, but if you see that I couldn't open it up properly with my balloons, so more than 50% residual stenosis was there. The lumen gain was there, but then I just put in a stent. She was 50 something. So she'll again land up with 3 months of anticoagulation, do the profile. I don't have to make a fistula for her because the vein drainage was very good there. So I hope that sorts some part of her troubles.
Yeah, correct, sir. So that's correct approach. Well, the stent positioning is much better when you go from a jugular route because you can go as distally as possible. So that's correct approach. Second question I'd like to ask, sir. In such patients having secondary varicose veins, post-biotic, having iliac vein occlusion, you did a stenting. Now, will you treat varicose veins or not?
I'll wait for some time because there's a good chance that the varicose veins only will be ugly and stop giving us problems. So now the patient will have to demand surgery for the varicose veins. This one was required.
Right, sir.
I wouldn't
So-
jump into the varicose veins right now.
Correct, sir. Correct. Last question I'll ask. What is a post-op treatment you will do? How long will you give anticoagulation to such patients?
At least 3 months.
Okay. Because in such patients, there's some study which say that you can even continue lifelong anticoagulation
Yes,
because the
at
risk
least
of
3 months.
thrombosis is pretty high.
Yeah, she will be at high risk of recurrent DVT because I have a metal there, and we want to see how it works. So 3 months to kahin nahi gaya. Most probably she is going to stay with it for life.
Correct. Any more questions from the floor?
दिग्विजय सर
जी
नमस्ते सर पहली चीज आई मीन द टेक होम मैसेज दैट एवरी varicose vein patients need to be examined carefully and diligently like you did. I mean, most of the times these vulval varicosities or signs of PTS are missed. So that's a very important message. The second thing is that upfront she presented with SFJ reflux and varicose veins only. That is later on that you digging up the history, you recognize this is secondary, not primary.
Yes, क्या होता है कि we get referred from all over the places, right? So the physicians will refer to us. उनके पेपर में जो diagnosis लिखा था वो मैंने पहले बोला. So we should not do a carryover bias of the diagnosis. Suppose a referral person has sent you a case with a particular diagnosis, don't just accept it. Work on those lines and do your own evaluation. ये मेरा take home point है.
So इसमें varicosities के अलावा was there any ulcer, discoloration,
No skin
lipodermatosclerosis?
changes, nothing. No skin changes, nothing.
So primarily we treated the occlusion for what all complaints? It's just the secondary varicosities.
Leg pain mainly.
Leg
थोड़ा
pain
सा
was there.
which I would not expect in this kind of varicose veins. और
Okay.
skin changes बिल्कुल नहीं था.
Okay.
leg pain बोल रही थी फिर ना बाकी आपको कभी DVT CVT हुआ है तो बोला हाँ मेरे को हुआ था DVT.
And what was the duration that she does not remember?
Of the
कब हुआ था DVT?
3 years back.
3 years back.
That
At
is why
that
the
time she
physician.
had completed the anticoagulation and right now
वो
also
she
she
doesn't
was
know much about that. वो history मेरे को पकड़ में नहीं है. She doesn't know how long she बोले बहुत सारी दवाई थी कुछ मैंने कितने दिन खाए मुझे खुद याद नहीं है. So that was like not correct. Somebody put anticoagulation on DVT, should follow it up and lot of things had to be done. शायद वो उसमें थोड़ा कुछ miss हुआ है. She doesn't know. She just know that खून पतला करने का दवाई मिले थे. That's it.
So just to brief the case.
I think excellent presentation. I just wanted to know, did you give aspirin also because you put a stent also? Just
No,
like we
sir,
do for, it's a large stent, I
yeah.
know. But do you give aspirin in addition?
सर
to the oral
अभी तो rivaroxaban full anticoagulation dose पे है सर. So अभी तो we don't generally give in a young person. But later on when we want to taper out, then some people do give aspirin. I would rather for this, I would go for anticoagulation over antiplatelet as far as possible.
Yeah, actually in coronary stents, what we do is, you see, we give aspirin plus oral, and the patient's atrial fibrillation needs oral anticoagulants for a long time. Then we stop aspirin after 6 months or a year or so, because it has been shown that oral anticoagulants are as good later on. But initially, because the stent can have thrombosis, so aspirin is added. But later on, adding aspirin, I think, is not really very much liked by the.
I agree, sir. Here in the veins, they are high flow systems, so we
Yeah, I
don't
agree.
actually need aspirin. We need to anticoagulate.
It is just like, say, coarctation of aorta or
Yeah, exactly.
aortic.
उसमें नहीं करेंगे aspirin तो वैसे ही
There we don't give, because it's a large
Large.
stent. We need not give it. Really.
And outflow पूरा खुला है ना सर इसमें. कोरोनरी में outflow में रेजिस्टेंस रहता है, तो आपको aspirin होना. इधर
I
तो
know.
But here the dictum
as-
is to give a but here we should give a long-term anticoagulation because the risk of rethrombosis is pretty high. Otherwise,
Oh,
stent tends to get occluded again in about 6 months or 1 year or so. So one should continue anticoagulation as much as possible.
I agree with you that it should be, because varicose veins are there and the patient will need it for a long time, maybe lifelong.
And
I
metal
would
in
agree
the
with
veins needs anticoagulation, sir.
Yeah, I agree. Good, very nice presentation.
Thank you, sir.
Short and sweet.
So I think we can move ahead with the second case with Dr. Rajnikant Shastri. Welcome, sir.
Thank you, sir. Okay, 1 second, sir. Is it visible, sir?
Yeah.
Yeah. Good evening, sir. Dr. Manchanda, Dr. Digvijay, Dr. Rohit, Dr. Kapil. So this was an interesting case which I came across, which we treated. It's basically this is a patient who had acute coronary syndrome and had DVT, and at the same time was finally found to be having factor V latent mutation. So I had a 32-year-old male, basically, who came in with central chest pain for the past 2 hours. It was a stabbing type of pain and gradually getting worse, radiating to the left shoulder and the jaw, and an episode of vomiting. The pain was not increasing with deep inspiration and no history of breathing difficulty. So on arrival, his BP was 140/80. He was oriented and pretty much sweating. Most of the examination was normal, sugar okay. Uh, we found out that basically on his pre-thrombolysis ECG was having ST elevation. So finding the checklist, the bedside echo was done, which showed anterior wall and anti-septal, septum distal IVS akinetic. EF was around 40-45%. So now he gives no history of orthopnea. He had a history of deep venous thrombosis 1 year ago, and patient was treated with anticoagulation and given warfarin for 6 months. So he does not give any history of clotting as per his as per the patient or his parents who had come along, and no history of coronary artery disease. Mother had diabetes, but that's all. He was a known smoker, but apparently he had quit after that episode of DVT. He used to smoke around 10 to 12 cigarettes a day, and history of consuming alcohol, is moderately obese. So initially we loaded him with aspirin, clopidogrel, atorvastatin. We gave him tramadol, and then we thrombolized him on the table. And after that, we gave him injection clexane as per his weight. Now, post thrombolysis, his ECG settled down and his pain also became better. So after that, we made a plan for coronary angiography after he stabilized. So now my question is that because he had a history of DVT in the past, we decided that possibly why not send a thrombophilia profile. And in the thrombophilia profile, as you can see, the APCR ratio came less. So possibly factor V latent mutation was there. So based on this, the question remains. In this case, as I said, we treated a patient was stable. Now the question is that because we put a stent in yesterday, so he's now on ecosprin, clopidogrel, and he was getting clexane. Now the question is, what should be the plan for anticoagulation here? Is dual antiplatelet enough, or in this case, do we give him rivaroxaban? We do triple anticoagulation therapy, or for 3 months, or what is the that's my thing. So internally we're planning to discharge him tomorrow, so I thought I'll use this forum to just ask a few questions as what to do further. That do we put him on rivaroxaban and stop ecosprin or single antiplatelet, or can we, being a young patient, use triple antiplatelet, dual antiplatelet with a anticoagulation also? Very short case, sir.
Excellent case, thought-provoking. So maybe Dr. Digvijay can give his inputs.
Well, two thrombotic episodes, factor V deficiency, anticoagulation to jayega. Platelets, we are not much used to it for venous, and coronary wise, yes. Venous wise, anticoagulation is required here.
Dr. Rohit, what's your take?
So what I will suggest that we should plan an angiogram, and if you're going for angioplasty, then we go for standard triple antiplatelet with aspirin, clopidogrel, and a Novak for a month, and then we stop aspirin after a month, and we continue with clopidogrel and Novak in full doses. After 1 year, we stop clopidogrel, continue with Novak. And I would like that we should do a Doppler again to look for any DVT, if it is there or not, and any other evidence of thrombosis. Else, if factor 5 is confirmed, then yes, lifelong we should give anticoagulation with a full dose in Novak after 1 year of angioplasty.
Yeah, so I think we can confirm factor 5 leading gene defect. We can do a genetic analysis and confirm whether the patient actually have a gene defect or not. And if yes, the patient does have a very high risk of more than 50% risk of having recurrent thrombosis. So yes, in such patients, lifelong coagulation is what I will recommend.
So, sir, coming back to the case again, angiography was done today and it revealed that basically there is a mid-LAD 95% stenosis, discrete lesion, and it had thrombus, so they did thrombosuction. So now again the question comes in, dual antiplatelet with anticoagulation for 3 months and switch over, or so
Dr.
they are
Shastri,
planning for a plasty.
Yeah, to this I'm going to speak in the next this topic also.
Sorry.
So
Yeah.
we did the same atrial fibrillation patient. We did angioplasty, and then what is the regime I followed. And yes, this is the next topic. Yeah, I'll show you there.
Yeah,
Maybe
I,
Dr.
think
Manchanda?
I would agree. It should be treated like atrial fibrillation because they are at high risk. And usually, what is done in this is you give triple therapy for about a month or so.
Yes,
Some
sir.
people have gone to 3, but the recommendations now say 1 month is there. Then you take off aspirin, you continue these 2 medicines for a long period of time. And after a year, you can take off the antiplatelets completely. And this patient should be on oral anticoagulants for lifelong, as because he has Claudin 5 deficiency. So I think this will be the same protocol as we do for atrial fibrillation.
Sir.
And these guidelines are now very clear about it, that how long you should give it and all that. So I think exactly like atrial fibrillation, because that is also high risk patient in which we do angioplasty. Aspirin has to be given initially because the stent thrombosis is high. For a month, triple can be given. So 1 month earlier, it used to be 3 months or so, 6 months, but the bleeding were much higher. So now I think most of the guidelines say 1 month is good enough, all the triple. Then you take off the aspirin. Because aspirin somehow is getting off from the cardiology now. It's a aspirin-free now sort of therapy which is being considered, because wherever aspirin was given, the bleeding was high. So there are a number of papers which say that aspirin can be taken off after even a month or even a week after a stent. So it should be clopidogrel plus a Novak, which should be continued. And Novak should be lifelong. After 1 year, there's no need of antiplatelet also, because single Novak is good enough.
Right, sir. So I think it was a good case. And if any questions, you can always write on the screen and we can later share with the
Yeah, I must also say that he has several risk factors, like he was a smoker and all, and exercise. Other things should be taken care of and all that thing. You see, in such cases, to see what has happened really, if you have the facilities, you should do the intravascular ultrasound, or you should see the to see what has really happened. We have done in several cases of acute myocardial infarction in which thrombus load was there. If there is an erosion, you don't have to put the sort of any stent. If there is a dissection, then you have to put a stent and all that. So I think intravascular imaging helps in these patients who have young people who have myocardial infarction. One should really know what has happened really. Erosion is also important, and erosion, if it is there, does not need any stent at all. Because once you take off this thrombus, the flow is quite good, and erosion does not. But if there's a dissection, yes, you have to put a stent and all. So I think intravascular imaging, if it is available, must be done in all cases who are having young MI. And it was done in many cases of COVID also. It was found that many of them did not need stent. So stents could be prevented. On the other hand, the stents could be put in those with even minor dissection. So they're likely to have this, again, a thrombosis. Good,
Right.
nice.
Kapil sir.
Yes. Hi, Tapesh.
Sir. So essentially, we have a patient who is young with 2 episodes of thrombosis, factor 5 laden mutation, and he has documented 2 thrombosis. So anticoagulation, there is no question, should be given. Antiplatelets, well, 1 or 2. Basically, we are having antiplatelets and anti-factor. That is the NOACs. Antiplatelets dual only if there is a foreign body introduced, like a stent, as Dr. Manchanda said, that if there is a dissection, you place a stent. Obviously, then you will need 3-pronged approach to block the platelets as much as possible, and also the factors, humoral factors that are there, which can form the clots. Now, the clots forming in the stent are actually the platelets adherent to the stent, the foreign body. So we have to block the stents dual, and we have to prevent the thrombus formation of the humoral factors by anticoagulation. So then if there is a foreign body, all 3. If there is no foreign body, anticoagulation plus single antiplatelet should be good.
Correct. So I think we can move ahead to the third case, which Dr. Rohit Goel will be presenting to us. So welcome, Dr. Rohit, and you can go ahead with the case.
Thank you, sir. Let me show you. Good evening, everybody, sir. Are my slides visible?
Yes.
Sir,
Yes,
I'm
yes,
going
we
to
can see.
discuss a simple scenario which was complicated before, that what to do in a patient who is known case of atrial fibrillation presented to us with coronary artery disease, and what should be a regime as antiplatelet therapy, sir. So my patient is a 67-year gentleman who presented to us with dyspnea on exertion and NYHA class 3 to 4 for 7 to 10 days with and palpitations. There no stiff and angina, pedal edema, syncope, no fever, cough, and a known case of hypertension and irregular medicine, sir. Sir, he was admitted at outside hospital with a diagnosis of hypertension with dilated cardiomyopathy with severe dysfunction, heart failure, and atrial fibrillation. In that hospital, he was given 2 DC shocks, but atrial fibrillation could not be converted to normal sinus rhythm, and he was kept on rate control therapy around 110 to 130 with oral amiodarone tablets. And echo showed global hypokinesia, dilated left moderate MR, severe TR, and so that hospital time of presentation, where we can see that there is global hypokinesia with the EF around 35%. This was, he came to us in August. So this is the poor heart function, which we can see. Dilated 4 chambers, moderate MR, and severe TR. So in our hospital, what we did, that AF was documented in the ECG, and echo showed DCMP with dilated cardium EF for 30%. We did an angiogram which shows single vessel disease, LAD mid 90% stenosis, the rest arteries were normal. And for atrial fibrillation, since he was already on amiodarone and he showed no clot, we again gave a DC shock of 200 joules, and he was converted to normal sinus rhythm. After converting normal sinus rhythm, we did an angioplasty of LAD with Resolute Onyx 326 mm, and we achieved a good TIMI3 flow. And he was discharged on tablet clopidogrel 75, aspirin 75, Epixaben 5 mg, and remaining heart failure therapy like Bimada, bisoprolol, Ditor tablets, and Tonac. This was the ECG at our hospital. It shows atrial fibrillation with flutter. And this is the ECG after giving DC shock. So we can see that atrial fibrillation is converted into normal sinus rhythm with prolonged QT and TV inversion V1 to V3. This is the angiogram of the patient done at the time of atrial fibrillation, and shows a single vessel disease of LAD of 90%. And this is the result after doing the stenting. So we have established the LAD, which can be the cause of poor heart function, or it can be tachycardia-induced cardiomyopathy because of atrial fibrillation. Now, after doing the angioplasty, what next? So the initially we used to put aspirin clopidogrel with warfarin acetone tablets, but maintaining INR was a big problem. But with the introduction of Novax and clear-cut guidelines, we were able to give the patient aspirin, clopidogrel, and apixaban for a month. And he came to us yesterday, and he was clinically, he was doing very well. NYHC normal, ECG with normal sinus rhythm, and echo with normal LV function with no MR and no TR. So if you see his echo yesterday, it was almost normal. So this was dilated cardiomyopathy with moderate MR, severe TR, treated with control of heart rate and stenting to LAD. And after a month, we stopped aspirin, and patient is now on clopidogrel and apixaban 5 mg BD with atorvastatin, with Bimada and bisoprolol. Because of this normal heart function, we were able to stop dietol tablets, and he is on now 2 heart failure therapies and 2 antiplatelet therapies. So coming to a discussion that now after the availability of Novax, the 3 trials were done in patients with atrial fibrillation needing angioplasty or managed on medically. So there are 3 studies. Pioneer is with rivaroxaban, Redual is with dabigatran, and Augustus was with apixaban. And all these 3 trials showed that we should give dual antiplatelet with full dose of Novax after doing angioplasty, and depending upon the risk of thrombosis, ischemia, we can taper aspirin after a month and then continue rest to platelet antitherapy later on. And we will confine our discussion to Augustus trial because this talk is on apixaban therapy. So Augustus trial, here 4,600 patients were taken, and it was randomized to apixaban 5 mg BD or vitamin K antagonist therapy to maintain INR 2 to 3. It was an open label study. Here clopidogrel was given to all the patients for 6 months, and aspirin was placebo. Aspirin was given on the day of presentation of ACS or PCI, and then it was left to discretion of the clinician whether to continue with aspirin or placebo after randomization. So it was double-blind study. P2 vital inhibitor like clopidogrel was given in all patients for 6 months. Primary outcome, they were studied major as well as clinically relevant non-major bleeding. Secondary outcome was death, hospitalization because of recurrence of MI, or death because of ischemia. So they have studied that whether it was major bleed or non-major bleed. When it was used with vitamin K antagonist with aspirin, the major bleed were maximum as compared to patients who were on apixaban and placebo, 7.3%. And if we compare vitamin K antagonist with aspirin, 18.7%, and as compared to apixaban, it was 13.8%. So we can see a marked reduction in the events with apixaban. And if you see the placebo, if you see vitamin K with placebo and apixaban with placebo, it will again reduce. So we can see clearly that apixaban leads to less bleeding as compared to vitamin K antagonist. And what about ischemic events? If you see apixaban versus vitamin K, if you see the risk of stroke as well as risk of hospitalization because of recurrence of MI, definite probable stent thrombosis, or patient needing urgent revas, again it was less with apixaban as compared to vitamin K antagonist. So this trial showed that with apixaban, when added to antiplatelet therapy, reduces ischemia as well as bleeding. And if we come to stent thrombosis risk after this antithrombotic regime, if you see vitamin K antagonist with aspirin as compared to apixaban with aspirin, if you see this green bar and this blue bar and red bar, we can see that apixaban with aspirin leads to less chances of stent thrombosis when compared to vitamin K antagonist with aspirin. And if you see vitamin K antagonist alone or apixaban alone, then again the risk of stent thrombosis is less with apixaban. So this trial clearly showed that the risk of stent thrombosis with apixaban is less than vitamin K antagonist with or without aspirin. Also, the number of death hospitalization was less in apixaban when compared to vitamin K antagonist, and all cause hospitalization, cardiovascular hospitalization, and bleeding related hospitalization were all less in apixaban, placebo maximum, followed by vitamin K antagonist and placebo, followed by apixaban and aspirin. So if you see the role of aspirin with placebo, aspirin leads to more bleeding as compared to placebo, and apixaban leads to less bleeding as compared to vitamin K antagonist. So combination of apixaban with placebo is a better and efficacy is similar in relation to stent thrombosis and ischemic events. So we all know that finding a good antithrombotic which could balance the risk of ischemia and risk of bleeding is very difficult for us. But now with the availability of Novax and well conducted these research trials, we are comfortable that a right combination of antithrombotic agents at the right dose and duration to reduce ischemia is needed at minimal cost of bleeding. The 2019 ESC guidelines for the management of chronic coronary syndromes also show that in patients who have chronic coronary syndrome and AF, when oral anticoagulation is initiated in a patient of AF who is eligible for a Novac, and Novac is recommended over vitamin K antagonist. And in patient with post-PTA patient who develop AF, then we should give Novac in a full dose of Apixaban 5, Dabigatran 150 or Rivaroxaban 20 mg OD in combination with antiplatelet therapy. So this flowchart is the most important flowchart which we should remember as interventionist. If we see if a patient comes to us with acute coronary syndrome, this is patient with atrial fibrillation. If he comes to us with ACS and we do a PTCA, then we give aspirin, clopidogrel and Novac for 1 week to 1 month of aspirin, depending upon the risk of bleeding, minimum 1 week and maximum 1 month. After 1 month, we can stop aspirin and we continue with clopidogrel either for 3 months or 6 months, depending upon the risk of bleeding and ischemia. And after 6 months to 1 year, we continue with Novac after 1 year, long term. And we stop clopidogrel at 1 year. And if we see medically treated ACS, like Dr. Shastri's patient, if you treat medically, then we give single antiplatelet like clopidogrel for 6 months and Novac for more than 1 year, lifelong. And if it is a chronic stable patient and we do PTCA, then we give aspirin for 1 week to 1 month, depending upon the risk, clopidogrel for 3 months, 6 months, up to 1 year, depending upon the risk of bleeding, and Novac for lifelong. So this flowchart helps us in making a proper treatment plan for the patient. Depending upon the risk of thrombosis and risk of ischemia, we can modify our medicine therapies. So to conclude, among patients with AF and recent PTCA with current generation of drug-eluting stents, definite or probable stent thrombosis is rare and occurs more commonly early after PTCA. And this data supports the use of Apixaban and a P2 vital inhibitor without aspirin during first 6 months for most patients, considering twice the risk of bleeding with the use of aspirin. And in patients with high risk of stent thrombosis and acceptable risk of bleeding, using aspirin up to 30 days after PTCA should be considered. And further studies to identify patients who might benefit the most are needed. Thank you so much for your patient listening. And all these 3 studies have made our life easier, that in AF post-PTCA patient develop AF, what should be our treatment plan? And this clearly shows that what should be our treatment plan and how should we go about it. Thank you so much.
Thank you so much, Dr. Rohit. It was a nice presentation. So as we can all see that all the NOACs have creeped into all our clinical scenarios in both our cardiology and our vascular fields. So in your opinion, any field still where vitamin K antagonists are preferred over NOACs?
Yes, sir.
Mechanical valves.
I think LV apical clot and prosthetic mitral valve, where still vitamin K antagonists, they are preferred over Novax, and we should not substitute. Still more data is needed. But yes, prosthetic, mechanical mitral valve and LV clot, we should use acetylcholine or vitamin K antagonist.
And significant valvular stenosis also.
Yeah, MS.
Yes, if a patient does not have a prosthetic valve, has significant, say, mitral stenosis, we would like to use VK preferable. These are the only 2 indications. Now, even after valve replacement, if it's a biological valve, the indications are that one can use the Novax. There's no need of oral anticoagulation. So even after surgery in mitral valve replacement, aortic valve replacement, one can use this VK. So only 2 indications are left. LV clot, there is still a controversy whether you should do it or not. Some people say you could use it, but there's no randomized study available. We have used in several patients. Once the clot sort of gets organized, then we give these Novax and all. But I think the guidelines are not very clear because there are no randomized studies available in the LV clot as yet. But anything which is floating, one should really avoid these giving VK and even fibrinolytic therapy and all that. So, I mean, there are certain unsolved problems still, but I think this is an excellent case, I must say that. And I think this very clearly shows this patient was diagnosed as dilated cardiomyopathy. But this is clearly a rate-related.
Yes, sir.
Several patients, not even ischemic.
Tachycardia-induced cardiomyopathy.
90% without myocardial infarction. Unlikely because his echo is normal. He doesn't have a scar. So it's very unlikely that just ischemia, whether he has ischemia, we don't know. It's a mid-LAD. Ischemia, if at all, will not be very, it's not even proximal. Whether angioplasty was needed, I'm not sure, but I'm glad it has been done. But I think this is a classical case of tachycardia-induced cardiomyopathy. I have several patients of atrial fibrillation. They come with the ejection fraction of, say, 30%, and then you just control the rate, or as he converted to normal sinus by cardioversion or whatever means, even medically, they become all right. So they are really pseudo-dilated cardiomyopathy, I must say. They're reversible causes of cardiomyopathy, and these are different than, now there's a new entity which I'm sure all of you know that it is a recovered ejection fraction. And these are patients who have dilated cardiomyopathy due to unknown cause, but once they recover, in those cases, we have to give these decongestive therapy properly. You see, this patient was not treated, I must say, with the 4 pillars of heart failure. He was not given the mineralocorticoids, he was not given the SGLT2. These are also very strong pillars for heart failure patients, and they must be given. And I think if you give these 4 pillars, that is, he was given beta blockers, he was given ARNI, Vimada was given, but he was not given mineralocorticoids.
So I have given Titor E at the time of discharge.
That's
Titor E, yeah.
You should also add, no, this patient is different. This is really a pseudo cardiomyopathy.
Yeah, so after
but this is a reversible cause. You see, if a patient has anemia, gets heart failure, he doesn't need all that thing. You see.
Yes, sir.
Once the cause is removed, once tachycardia is removed in this patient is completely recovered. His muscle is quite normal.
Yes, sir.
I think those patients who are recovered, but when patient comes in heart failure, I think SGLT2 have a very strong sort of, they are possibly the best. And they are actually started very early, according to us, because dose is fixed and they do not cause hypotension, etc.
Yes, sir.
All these ARNI, etc. has to be built up for a long period of time. And beta blockers also, you can't give high dosages, especially if they are having if they're having low blood pressure, which is very common. So I think excellent case, which shows many things that atrial fibrillation itself can cause cardiomyopathy with a fast rate. And then once you convert it to sinus rhythm and the heart rate is controlled, that is cured. Of course, ischemia can also cause this thing, but that is a little unusual because repeated, it has been shown that hibernation can cause, there's one case report long time by Dr. Braunwald, that repeated hibernation can cause LV dysfunction, but not atrial fibrillation. So I think this is an excellent case, and this gives us a lot of lessons. And I think the review of literature, Augustus trial was extremely good. I think all these controversies have come to rest now, that how long we should give. Aspirin should be taken off as early as possible, as he said. And only oral anticoagulants after 1 year, even after angioplasty and all. I think very well done.
Thank you so much, sir. Thank you.
Any questions from the floor or any comments?
Sorry, one question. Dr. Rohit, in this case, as you, what are the chances, supposing if there is a stent in of using ticagrelor instead of clopidogrel?
Sir, actually, these studies which were done with 3 Novax, they have involved only 5% patients with on ticagrelor. So still data is more robust with clopidogrel because ticagrelor can lead to more bleeding when used with Novax. So I think clopidogrel, we should continue with clopidogrel, but if patient is young and the risk of thrombosis is less, bleeding is less, then we can try ticagrelor, but still data is very sparse. We should continue with clopidogrel, cosprin, and Novax.
The benefit was there was ticagrelor also, although the number was small. The only problem with the this clopidogrel is that a lot of resistance cases are there. If there's a proven case of clopidogrel resistance, these tests are not done anymore these days. Earlier they used to be done. But if a patient is known to have clopidogrel resistance, then it's better to avoid it. Otherwise, I agree with you. Clopidogrel is the drug of choice. And it has never been compared with the ticagrelol. I wish sometimes some studies are done, because one is a cheap drug, other is costly. But I think clopidogrel is a good drug, but except resistance, which may occur in some patients, if it is a known patient. We don't do to these resistance studies anymore. Earlier we used to do it, not now.
Okay, so coming back to the vascular field again, vascular field, as we have discussed about the indications for vitamin K antagonist in cardiology field and vascular, we do give in patients having antiphospholipid antibody syndrome, APLA syndromes, still the vitamin K antagonists are preferred. Secondly, patients who are presenting with a DVT in pregnancy or lactating females, they are still the traditional vitamin K antagonists are preferred over NOACs, as we don't have any data in such fields. So in vascular also, both in DVT, in embolism, and in arterial, now all the NOACs have really proliferated very well and now being used widely and extensively. And I think we all are using all the three molecules pretty widely with I don't think there is too much difference, but yes, there are some clinical scenarios in which one is preferred over the other, but yes, all the three drugs are quite comparable in their safety and efficacy. So any comments from Dr. Digvijay?
Yeah, we should not forget CKD patients. There also warfarin is better off.
Yeah, with the Apixaban, Eliquis, that is now preferable. Is a good NOAC to be used in eosinophilic patients.
Yeah, you see, there's a real world study. It's a huge study which appeared only recently, a couple of months back, although there's no head-to-head comparison. But it clearly shows that real world study of lakhs of patients comparing all the three shows clearly Apixaban has the least sort of bleeding and has the maximum efficacy. So I think that real world study, although it's not a head-to-head comparison, clearly shows that Apixaban is possibly the safest and therefore most effective in most of the patients. And it can be, as you said, given in renal failure. There are studies in elderly people also, it can be given. So I think there are studies available. So I think the choice of these NOACs with the cardiologists has become Apixaban. Most of the cardiologists. Of course, there are indications for others also, but for cardiology, I think Apixaban seems to be. And these these real world studies clearly show that it is much superior. Of course, they have their limitation. They are not head-to-head comparison, but this is what it is.
Any remarks from Tapesh?
Sir, in pregnancy, you said acetrom?
In pregnancy, we are still giving low molecular heparins.
Yeah, so only low molecular weight heparins in pregnancy and
no, that's not true. You see, there are a number of patients who have valve replacement, they become pregnant. And I think we reported long back, 30 years back, 100 patients who became pregnant. They were having valve replacement. Young people in India get it. They were already on AK. So it is suggested, of course, we don't even know that most of the patients don't know they are pregnant, in India at least. First 4 to 6 weeks, it's best to avoid these. One can give oral, but 6 weeks doesn't matter really. After that, you can continue oral, but you can give it till 38th week, and elective, then you should change over to heparin and then do the elective cesarean, because you don't know what's going to happen. And the results are not bad. Theoretically, yes, there can be problems with the VKA during pregnancy and all. Practically, we are not seeing much. There are slight increase in the incidence of fetal abnormalities and bleeding, but overall, this is the practical thing. And there are a number of series available now, oral anticoagulants during pregnancy in patients who have prosthetic valves and all. So I think first 6 weeks, they say better to avoid, but that is really not known to most of the patients. But in the last 4 or 6 weeks, one could change it over because, and then preferable to do cesarean in these patients. And the outcomes are not bad. There are very small cases of heparin-induced, even embryopathy, etc., are known and so on. But practically, this is fairly safe because large number of patients in India do require anticoagulation because they become pregnant. Although we tell them not to, but they do. And of course, anybody who wants to become pregnant, we always advise them to get biological rather than the prosthetic valve. But in India, it has been happening. And number of series from India, from Brazil, and several other countries have shown that it's possible to have normal deliveries in patients who are having oral anticoagulants.
If any closing remarks from our esteemed colleagues?
We are done, I think.
Okay. So, Dr. Manchanda to close the session.
Yeah. Well, I have a very pleasant duty to thank all these speakers. They're extremely good cases and very brief and to the point and excellently presented, and review of literature were excellent. And of course, the moderators did an extremely good job. So overall, I think this was a good learning, at least for me, I'm sure for most of the other people also. And those who are listeners must be a lot of learning points there. Again, showing very clearly that this clot, which can harm the patients either in the veins or arteries, if we use proper medicines, could be tackled to a great extent, even in very, very difficult cases. As you saw, the first case was so difficult, such a long stent was put in, nothing was from the jugular and all. And the other two cases were also very, very interesting. So thank you very much, all of you. And I'd like to thank the organizers also for having organized this good teaching seminar. Thank you.
Thank you, sir. Thank you. On behalf of Emcure, would like to thank Manchanda sir, Kapil sir, Tapish sir, Rohit sir, Digvijay sir, and Rajnikant sir for your valuable time. Definitely the interesting cases that have been discussed and the insights through this cases and discussion would help all the viewers of this session, sir. And next month we'll be back with the another interesting cases and the session. Till then, goodbye, sir. Thank you. Good night.
Thank you. Thank you. Good night.
Good evening, sir.
Thanks a lot, each one of you. Did a great job.
Thank you, sir. It was
Good
a pleasure
learning.
to-
Thank you, sir.
And at my age. Thank you.
Pleasure, sir.
Thanks a lot. Good night.
Good night, sir.